Good afternoon and welcome to the last grand rounds of the year. It's a pleasure to see all of you, and the attendance this year has been fantastic. I just am really pleased that so many people do attend grand rounds. And Suzanne, something that we should probably do is to try to find out why people attend grand rounds, and what we can do better to have more people attend grand rounds. But I am very pleased with the way grand rounds have gone this year, and we've tried to use the same template for our next year's series of speakers. In terms of choice, we've involved the division heads, we've involved the vice chairs, and we've also involved the medical chief residents in terms of making decisions about who to invite and what the balance will look like. And we have an exciting group of speakers that are beginning to be signed up for next year. So I encourage you to look at that list and to save Wednesday at 12 o'clock for medical grand rounds. Today we have a very exciting speaker, Kristen Demoruelle, to present grand rounds to you. Kristen is an assistant professor in the division, in the Department of Medicine in the Division of Rheumatology. She received her undergraduate degree in biochemistry from Delta State University and went on to receive her MD degree from the University of Mississippi. And then we were fortunate to recruit her here as a resident, first intern resident, and then she stayed on to do her fellowship training in rheumatology. During her rheumatology fellowship, she became very interested in rheumatoid arthritis and in the early diagnosis of rheumatoid arthritis. And to pursue this further, she decided to get a PhD in clinical sciences, clinical research. And I don't know whether she's completed her PhD yet, but you have? In August, she will have completed her PhD. So she will join the few fearless individuals that have got an MD as well as a PhD. She has exercised her research and pointed her research in what I think is a fascinating direction, which is to try to identify the site at which rheumatoid arthritis starts, where that autoimmune response initiates, and then how it permeates and becomes a systemic disease. And even more interesting, her focus is on the lung, which I've always viewed as the most interesting organ in the body. And I view it as the most interesting organ in the body because it's the most interesting biological and immunological interface with the environment. And it turns out that rheumatoid arthritis may be initiating its immune and autoimmune responses in the lung. And that happens to be the subject of Kristen's successful K23 award that she is actively pursuing. So today she's going to talk with us about 6 differences in the development of rheumatoid arthritis, and I hope she touches on lung. So let's welcome Kristen.
Yeah, thanks. Thank you for that fantastic introduction. I will touch on the lung, but I'll also try to be provocative with other mucosal sites as well. It's the last grand rounds of the year. Thanks for everyone's attention. And hopefully I'll mention some things that you may have heard before related to the lung and how that may be involved in the development of rheumatoid arthritis. And as I mentioned, we're touching on some other areas that I'm particularly interested in, which is sex differences in the development of rheumatoid arthritis. I have no disclosures. So for this talk, I'll cover 3 primary objectives. First, I'll discuss some of the established data about sex differences and the clinical characteristics and the epidemiology of rheumatoid arthritis. I'll then discuss what we know about the development of RA that includes understanding this preclinical period of autoimmunity and how that helps inform our understanding of disease development, especially the early stages of RA development. And then I'll end with some of the research from our group that's trying to understand these sex differences in rheumatoid arthritis with a novel approach that looks at mucosal antibody generation. So just to make sure we're all starting on the same page, rheumatoid arthritis is a systemic autoimmune disease that primarily affects the joints, though it can affect other organs such as the lung. It has a characteristic pattern of joint inflammation, primarily involving the bilateral hands as well as the feet, but can affect other joints as well. And this figure, the picture on your left, shows you the swollen hands of an individual with rheumatoid arthritis. So this joint swelling can cause symptoms in an individual: pain, stiffness, swelling, but it can also lead to joint destruction, which is shown in the X-ray figures on the right. You can imagine that this leads to disability, which is impactful for patients' lives, and it's an unwanted consequence of the disease. So rheumatoid arthritis is the most common form of autoimmune arthritis that we see. It affects about 1% of the population, so that's a little over 1.5 million people in the United States. And if you want to think of it in terms of a Denver Broncos game, hopefully many of you have been to at least one, rheumatoid arthritis would affect about 1.5 sections of the fans at a Denver Broncos game. So that's a significant amount of people, especially when you think about the fact that rheumatoid arthritis is associated with disability, increased mortality, and substantial healthcare-related costs. Unfortunately, we don't know the cause or the etiology of rheumatoid arthritis, but we do think it's likely a combination of genetics plus environmental or external factors that interact with the immune system. And importantly, and I'll touch on this again later, if we can understand what causes rheumatoid arthritis, we can ultimately try to prevent the disease, which, as I mentioned, is disabling and very costly. Prevention is really the goal that we're trying to achieve in rheumatoid arthritis, and you may be familiar with prevention trials, including one that's being conducted here by Kevin Dean, trying to prevent rheumatoid arthritis in high-risk individuals with a pill called hydroxychloroquine. But importantly, the place that we really like to get to is where we can understand what causes the disease within an individual so that we can actually personalize our approaches to prevention and target the specific mechanisms causing disease. And so, as I mentioned, we'll start with some of the sex differences in the clinical presentations of rheumatoid arthritis. So RA is about 3 times more common in women compared to men. And the disease course and prognosis differs between men and women. This is a figure to demonstrate the sex differences in incidence of rheumatoid arthritis. And I think I can point with this. So this is an epidemiologic study out of Norway with the incidence per 100,000 of rheumatoid arthritis along the y-axis, broken up by age groups here. You can see that females are in the light blue and males are in the dark blue. And at each age group, the women have a higher incidence of RA than the men. What's also interesting is that if you look at the female-to-male ratio, which is along the top here, for each of these age groups, you see that in individuals who are less than 50 years old, presumably most of these women are premenopausal, this female-to-male ratio is quite a bit higher than when we look at older individuals who are over the age of 50. Similar results were seen in an epidemiology study out of Rochester, Minnesota, where they also looked at the annual incidence of RA per 100,000 and broke them down by age group. I'll add in the female-to-male ratio for you on the side. But you can see that overall the incidence is higher in women compared to men. But again, in these younger individuals, presumably women who are premenopausal, the ratio of RA incidence is higher in women compared to men, compared to when you have an older individual. In addition, the prognosis is worse for women compared to men for rheumatoid arthritis. I'll give you a few specific examples. Women are less likely to achieve disease remissions. This is based on various criteria that we use, including swollen joints and painful joints. And one study found that at 2 years of treatment, only 32% of women compared to 48% of men had achieved disease remission. In addition, women had a worse functional status compared to men with rheumatoid arthritis, and this was based on various questionnaires of functional status. And one study found that female gender was an independent risk factor for radiographic progression in rheumatoid arthritis. And radiographic progression for us is often associated with disability. So you can see that overall women have a worse prognosis than men when they develop rheumatoid arthritis. So what are a few potential mechanisms that could explain these sex differences in autoimmunity in general and may also relate to rheumatoid arthritis? I'll just mention 4 kind of general categories. It could be that there's factors encoded on the X or Y chromosome that influence disease development. It could be an immunologic phenomena unique to pregnancy. It could be sex hormone influences on the immune system that influence development of disease. Or it could be a sex-specific environmental or occupational exposure, perhaps something that women are more likely to be exposed to than men. And while all of these potential mechanisms are worthy of investigation and what might cause this sex differences in rheumatoid arthritis, I'll focus on the last 2, and first looking at sex hormones and the immune system. So in general, women have a more robust cellular as well as humoral immune response compared to men. This has been shown in studies where they stimulated T cells, and women have more T cells become activated upon stimulation. Estrogen stimulates B cell production of antibodies, and subsequently women have higher levels of both total IgM and IgG. And with this, studies have found that women are better protected against infection, likely explaining a survival advantage in women over men. But it also increases a woman's potential to develop an autoimmune response. And so when we think about the specific effects of sex hormones, estrogen, progesterone, testosterone, on the immune system, it's quite complex. And I'll demonstrate the complexity with one slide that I'll walk you through. This is just estrogen, so not even considering the other 2. Estrogen is sort of the most studied one in immune cells. And you can see that if you look at the estrogen levels, so going from low postmenopausal to high pregnancy states of estrogen, it affects many different cells in the immune system. If you look at green being it stimulating that cell versus orange inhibiting that cell, some cells are stimulated regardless of the level, whereas some cells are stimulated with lower levels and inhibited with higher levels. So I show this to say that it's a very complex process, and with that it's really unclear what the role of sex hormones is in rheumatoid arthritis, although it's possible that estrogen and progesterone could play a protective role. That's sort of suggested by the fact that menopause, as well as the postpartum period, which are low estrogen and progesterone states, are associated with an increased risk of developing rheumatoid arthritis. And many of you know that RA improves with pregnancy, being a high estrogen and progesterone state. So if we next look at sex-specific environmental factors that could be associated with these sex differences in rheumatoid arthritis, I'll mention that there are many different exposures or environmental factors that have been associated with an increased risk of developing rheumatoid arthritis, and I'll just mention a few very quickly. There are several that are inhaled, several that are related to your diet. There are some that are related to bacteria, and then there are many that are specific to women, and I've just outlined them here. So nulliparity is associated with an increased risk of developing rheumatoid arthritis. What's interesting is that that would mean that having a pregnancy would be associated with a decreased risk of rheumatoid arthritis. However, that first year postpartum is actually a very high risk time for developing rheumatoid arthritis. A lack of breastfeeding, a lack of oral contraceptive pills have been associated with an increased risk of rheumatoid arthritis development. Preeclampsia, early menarche, early menopause have all been associated. What's important to note is, one, these are exposures that are not, you can't take out the sex hormone influence here or the pregnancy-associated factors that may also be influencing these exposures, but they are things that can differ in exposures between women and have been associated with rheumatoid arthritis. What's also important to note is that these studies have looked at women who have developed established rheumatoid arthritis, so they've already developed joint disease, and what we don't know as much about is how these different female-specific factors influence the development of RA-related autoimmunity. So I'll move on to autoantibodies. As you know, we love autoantibodies in rheumatology, and they're important in rheumatoid arthritis also. So I'll focus specifically on the anti-CCP antibody, which stands for anti-cyclic citrullinated peptide antibody. We use this often to diagnose rheumatoid arthritis. It's very specific for rheumatoid arthritis in the setting of a swollen joint. It's also been found to be related to joint disease pathogenesis, so plays a role in disease development. The anti-CCP antibody that we're looking for is targeting a citrullinated peptide or protein. And citrullination is the post-translational modification of an arginine amino acid to a citrulline. This is something that happens naturally in everyone related to inflammation and other biologic processes. So it's natural to have citrulliнаted proteins. It's just not normal for people to develop a sustained autoimmune response to them. I will mention that when we test for an anti-CCP clinically, there is an ELISA test that we can test clinically. Perhaps many of you have ordered them in your clinical practice. And when we look at this test, we're actually testing for a combination of various citrulliнаted proteins that the person has an antibody to. So the anti-CCP is relevant also because it's present before individuals develop the joint disease that diagnoses rheumatoid arthritis. So many studies have now shown that these antibodies are present in the serum of individuals about 3 to 5 years before they actually develop joint inflammation and get a diagnosis of rheumatoid arthritis. We call this a preclinical period of RA, and most individuals are not symptomatic during this time. Studies have shown that their joints can be normal during this time, but their antibodies are present in the blood. If these antibodies are present in the absence of synovitis, this is predictive of developing RA in the future, so it's a marker of having a high risk of developing joint disease in the future. This identification of this particular preclinical period that we call it has really revolutionized our understanding of how RA develops. And basically, I'll outline very generally what we think about the development of rheumatoid arthritis is that it develops in multiple phases, where one starts with a genetic risk, encounters an environmental factor that triggers an autoantibody response, in this case, the anti-CCP antibody. And this can then transition to inflammatory arthritis that we classify as rheumatoid arthritis. So this is the time point when the individual comes into the clinic and is diagnosed with rheumatoid arthritis. But importantly, this preclinical period prior to the development of joint inflammation suggests a few things. And one of the important ones that I'll mention is that the anti-CCP likely comes from a site outside of the joints, since we know that it can be present in the setting of normal joints. A lot of data suggests that perhaps a mucosal site could be one where the environment interacts with your immune system in a way that could trigger autoimmunity. And I'll mention again the importance of, if we can identify what causes this autoimmunity, we could potentially target specific mechanisms for prevention. So how do you study the preclinical period? I mentioned that these people don't typically have symptoms. They have an antibody. They probably don't know about it. So how do you study that period? And we study that through a cohort called the Studies of the Etiology of RA, or SARA cohort. This was established many years ago now by Drs. Mike Holler and Jill Norris. It's designed to investigate these preclinical stages of rheumatoid arthritis that I mentioned. We follow subjects who we consider to be at risk for rheumatoid arthritis, and we consider them to be at risk either based on familial risk factors or serologic risk factors. And specifically, a familial risk factor for us would be defined as being a first-degree relative of someone with rheumatoid arthritis, so that does increase your risk above the general population. We also go out to the health fairs and identify people who have anti-CCP positivity based on broad population screening that we perform and don't have inflammatory arthritis. And sometimes you guys check an anti-CCP in clinic and they see us in the rheumatology clinic. We don't think they have joint inflammation. And so now we've got somebody who has an antibody who doesn't have joint inflammation, and they would also fall into this at-risk category. To remind you of that little figure that I showed you about these phases of disease development, this preclinical period covers kind of a spectrum of preclinical disease, from genetic risk, which may or may not progress to actually develop inflammatory arthritis, to someone who's already developed antibodies and may be very close to developing inflammatory arthritis. But we think it's important to study the whole spectrum because we can learn a lot about the disease development along all these different steps. So if autoimmunity in RA starts at a mucosal site, which one? We heard there's several candidate mucosal sites, and we alluded to the lung as a potential site, and I'll mention that first. So there's a lot of data to support that the lung could be a site where RA might be initiated. For example, smoking is the strongest risk factor for rheumatoid arthritis. Smoking is also associated with increased citrullinated proteins in the lung, and as I mentioned, those are the antigen targets of these antibodies that are associated with the disease. Many patients with RA have underlying lung disease. And then our group did a study in 2012 that did high-resolution CAT scan imaging on individuals with serum anti-CCP antibodies and other rheumatoid arthritis-related autoantibodies that didn't have any joint inflammation. And we found a high proportion of those individuals had evidence of airway abnormalities suggestive of inflammation that were not seen in anti-CCP negative controls. This is a picture to show you that one figure from that study where this individual has airway or bronchial wall thickening that was not seen in as high of prevalence in individuals without the antibodies. So this led us to some additional studies to look at the biology of the lung. And we've been doing sputum studies as a way to easily sample the lung in a large number of people. We collect induced sputum samples with hypertonic saline, and we test them for anti-CCP antibodies. So this is a combination of published and unpublished data that shows you in general what we found with these studies. This figure shows you the sputum anti-CCP level in ELISA units along the y-axis. We've got the three groups that I mentioned, a control group, our at-risk group, and individuals with rheumatoid arthritis. This is the median level, and we established a cutoff level of positivity here based on our control group. The closed circles are individuals who are serum CCP positive, and the open circles are those who are serum CCP negative. And I'll point out a few things here. One, in individuals who have rheumatoid arthritis, a large portion have elevated sputum anti-CCP antibodies. Also in this at-risk group, a portion do also have elevated levels of sputum anti-CCP. Some of those individuals are serum anti-CCP negative but have high sputum anti-CCP levels, suggesting that perhaps at least in a portion of individuals, the lung may be an initiating site of these antibodies in some individuals. But what's also interesting is below the line. So we found that there was also a portion of individuals down here. It's hard to see because there's a lot jumbled up there. But there were individuals who were serum anti-CCP positive but were sputum anti-CCP negative, suggesting that perhaps another mucosal site may be involved in these individuals. As I mentioned, there's a few candidate mucosal sites of interest. Other ones are fair game, but in wondering what could be related to sex differences in rheumatoid arthritis causing the prevalence and incidence to be higher in women, we next looked at a mucosal site that's very specific to women, so the cervicovaginal mucosa. And our hypothesis was that the CV mucosa could be a mucosal site of anti-CCP generation that might be unique to women, and perhaps this could explain the higher rates of RA in women. So in conclusion, RA is more prevalent in women, and so if you see a patient in your clinics and they have a swollen joint, especially if they're a woman, you should consider rheumatoid arthritis. If we can identify the origins of autoimmunity and rheumatoid arthritis, we can target prevention, and so these are areas in which the field is moving forward. And also, based on these early studies, it may be that some women with and without rheumatoid arthritis demonstrate localized anti-CCP generation in the CV mucosa. Perhaps this is a unique mucosal site for some women to generate autoimmunity, and potentially it's related to localized inflammation from potentially a variety of different sources. To mention, again, these four potential areas that could influence autoimmunity and sex differences in rheumatoid arthritis, I think it's also important to focus in future studies on how these different factors could specifically influence mucosal biology. And I will try to convince you of a hypothesis that the CV mucosa could be an originating site of autoimmunity in rheumatoid arthritis for some women, and perhaps it's through the following mechanism: that within the female genital tract, there's local inflammation for some reason, whether that's the state of the menstrual cycle or an IUD or something else, an infection. Perhaps this generates citrullinated proteins locally that in some people generates a local autoimmune response. And then in some individuals, this becomes systemic through local lymph nodes, regional lymph nodes that could then become systemic, where we can detect these anti-CCP antibodies in the blood, and then ultimately these individuals may develop inflammatory arthritis that we diagnose as rheumatoid arthritis. So going forward, our group is looking at various mechanisms that could be triggering these anti-CCP antibodies at mucosal sites. I apologize, it says ACPA, which is another term for anti-CCP. A couple of things that we're interested in are, is there an increase in general citrullination associated with these anti-CCP antibodies, or are there specific citrullinated proteins locally that are associated with these antibodies? Are there changes in specific inflammatory cytokines, either locally or systemically associated with local anti-CCP generation? Are there increased mucosal levels of neutrophil extracellular traps, or NETs, which is an area of interest in rheumatoid arthritis because NETs can expose citrullinated proteins to the immune system? And we're also looking at factors that may be associated with transitions from local antibody generation to systemic to joint disease. And I'd like to thank a variety of people, many who are here, but we have a large group in the rheumatology division that works on these studies, including Kevin Dean, who's here and my primary mentor. I also work with the Center for Women's Health Research, including Dr. Judy Regensteiner and Nanette Santoro, and they've been very helpful through the Center for Women's Health Research and the Birch grant here that sort of got many of these studies spearheaded. And then a collaborator at the University of North Carolina, Chapel Hill, who, through some HIV studies, sort of helped us out with the protocol for the self-collection of these samples. And with that, I will take any questions.
Kristen, thank you very much. Let me just ask the first question. Are you suggesting that there are a number of mucosal sites, not just one mucosal site, that could initiate this autoimmune response?
I do think that that is likely the case. I think when we started with the lung, we thought a majority of individuals that would make a lot of sense because of the smoking associations and the lung disease. And I think what we found in our studies so far is that it does look very relevant for a portion of people, about 25, 27%, depending on who we look at. But as I mentioned, there are definitely individuals who have systemic antibodies, and we can't find a high level in their lung. And I think that does suggest that there could be other mucosal sites involved. What I don't know is it one mucosal site that differs between individuals, or does someone start with one mucosal site and then as you have multiple mucosal sites become involved, does that sort of tip you over the edge in some way that progresses towards disease development? The lung does interact a lot with the environment, but obviously these other mucosal sites do as well. So,
other questions? Questions from the House staff first. Okay, Annie.
Just any thoughts you might have around eye makeup and lipstick generally used in women?
That is an interesting question I have not thought about. I'm not familiar with any data related to inflammation, but I'm curious.
In the integrative medicine world, there's some thought about immune stimulants in some of the cosmetics, and it's sort of an emerging field of integrative medicine research.
Very interesting.
Hi. From an evolutionary perspective, a disease affecting a woman in the prime of her childbearing years should not be advantageous. So I'm wondering if modern-day childbearing, such as delaying childbearing into older age, has an effect, and if anyone's looked at that.
A lot of the studies are older that have looked at these incidence rates, but some of the studies that have looked at delaying pregnancy do seem to perhaps be associated with higher rates. Some of that may be that if these immune responses, I mentioned nulliparity is associated with an increased risk of rheumatoid arthritis, so it could be that not having a pregnancy during a particular time may influence it. I think it's interesting. So I also think about, why would something like this affect a woman of childbearing age? That shouldn't be advantageous. But I think it is interesting, this balance between, protecting yourself from infection so that you can successfully have a pregnancy, and then maybe it just gets tipped over for reasons that shouldn't happen, and it is prone to an autoimmune response. I'll also just mention that the menstrual cycle is kind of interesting because those 3 phases during that early follicular phase, that's actually a high infection time point locally because you've got sort of a thin lining. So it is common to have a more robust inflammatory and antibody response because you don't want to get infection. And then that should calm down around ovulation when you need to, have a pregnancy successfully. And so I think there are things about the natural cycle and pregnancy that are very interesting and potentially very relevant to this disease.
In vitro, what's been shown to modify these proteins to cause them to be citrullinated?
Citrullination happens often. A big one is inflammation. Smoking specifically has been looked at as a specific cause of inflammation. Intracellular citrullination sort of modifies various gene expression, but that should be intracellular and not necessarily exposed to an immune response. So it's possible that even these regular factors that are occurring, if they become extracellular, for example, apoptosis or netosis, that might actually expose a once intracellular process extracellularly to your immune system. So I think those are some of the areas we're kind of looking at as to how this naturally occurring process could trigger an abnormal response.
Judy?
Excellent talk, Kristen. That was terrific. I have a question. Is there a relative increase in the prevalence of rheumatoid arthritis that you see? In other words, I know the population's going up, but aside from that, do you see an increase?
You mean over time? I think this addresses your question, but so what is interesting, I mentioned the Rochester, Minnesota epidemiology study that showed the higher incidence in women compared to men. It also looked at changes over time, and overall incidence rates were decreasing until around 2000 when men have stayed low, potentially decreasing, but certainly not increasing. But it does seem like in that study, women were slightly increasing between 2000 and 2007. And it does beg the question of what has changed during that time point. It didn't look like it was associated with smoking in that particular study. I don't think they were able to look at contraception and things like that, or pregnancy and timing of pregnancy, but it is very interesting.
Hi, Kristen, very nice talk. So is there evidence that looking at the male to female predominance, that there's a different disease course in women than men? For example, is the disease more severe in women than it is in men? Are outcomes worse? Is survival worse? And then I was getting to that to your sort of prevalence. So I couldn't figure out if that was an incident or prevalent chart when you're looking at diagnoses at around childbearing age. That then the ratio changed later. Was that then incident cases?
Yep.
Okay, so that's not, so it's not a dropping out of survival at this point. But just is there a role for estrogen in disease pathogenesis and propagation disease?
Yeah, it's a great question. So the prognosis that I kind of mentioned is a little bit worse in women. I think trying to tease that out as to whether or not it's specifically related to hormones versus at least one study that showed women for some reason didn't get in to see rheumatologists as soon, and maybe there's a delay in treatment. But overall, women do have a worse prognosis as far as disease activity, not having remission, and then poor outcomes as far as their joint disease. Survival, I can't think of off the top of my head overall. Certainly people with rheumatoid arthritis tend to have an early mortality related to cardiovascular disease and whatnot. And then your second question was related to...
Well, I think you answered that in terms of incidence,
yeah.
But I guess I would ask, how about disease location? So is lung disease more prevalent in women, or is cardiovascular disease more
great
prevalent?
point. Don't have time to mention everything, but so I'm glad you brought that up. So what's also very interesting for a person studying the lung and other sites, so the lung has been more strongly associated with men developing rheumatoid arthritis compared to men, and that's been shown in a few different studies, which to me would suggest that the lung is very important, but it may be more important to a man developing rheumatoid arthritis, and maybe there are other factors that are more strongly related to women, such as all the various factors that I mentioned that are sort of specific to women. But yeah, it's very interesting that it does seem to have a sex difference in its risk of developing RA with smoking in particular.
So, Kristen, the sex ratio remains after the menopause. It's still 2-to-1, isn't it? So what are your thoughts? Should the CV mucosa be examined in postmenopausal women too to see if there are factors there unrelated to the menstrual cycle and IUDs that may be causative? What are your thoughts?
Yeah, I think it is important to look at. I had focused on the premenopausal period, kind of interested in some of these, the hormones changing basically. But if it could be some sort of generalized inflammatory response, that should not necessarily be limited to a premenopausal woman. So I would suspect that you might not necessarily see fluctuations throughout the month, but I think it's certainly possible that another source of inflammation at that mucosal site, even in a postmenopausal woman, is absolutely of interest to look at. Yeah.
What's the average length of time that people without RA will have the anti-CCP measured before they get the joint manifestations? Are we talking a couple of years or 10 years?
Yeah, it's about 3 to 5 years on average. So there's a few things that sort of influence that, but about 3 to 5 years. Long enough for you to get a prevention trial funded by the NIH. But long enough, too, that we go to these health fairs and do this broad population screening to identify these people, and we've watched several of them develop rheumatoid arthritis over a couple of years.
Have there been studies where you've just taken the random population as opposed to people that are expressing interest in it, that are coming to clinics and going to health fairs?
To look at the prevalence? They do a lot of these like biobank studies, especially in European countries. And so with that, they do sort of look at the prevalence of the antibodies. But I think most of them have looked at kind of this outcome of developing rheumatoid arthritis and looking backwards. There was a study out of Mexico that just looked at people who had an antibody positive and then followed them over time. They saw similar to what we saw, that a portion of them will develop arthritis over a couple of years. So we have looked at the broad population screening as best we can, but you are right that you can't help someone stopping by the table because maybe they feel a little achy, and that might be why they decided to get screened. But I would say we're very pushy at the health fair and try to get everyone tested. Some of our staff is here. We do try to do the best we can, but it could be influenced by that.
I have a question actually from one of our other sites. One of the residents asked that you mentioned genetic susceptibility interacts with environmental influences in RA pathogenesis. There are some genome-wide association studies showing association of certain SNVs with RA. Have you used any of these SNVs in screening your patient population for those with predisposition to RA prior to doing your analysis of exposure risk factors?
I will try to answer that by talking about the shared epitope, which is sort of a genetic risk allele that sort of encompasses a couple of different genetic variations that have been associated with rheumatoid arthritis. We do test all of our subjects for presence of the shared epitope. We can also look at the individual genetic risk alleles. We, at least in these studies, haven't seen an association with the antibody development. Some studies have looked at, so I'll mention again, this preclinical period, sort of new in the last decade and a half. It has really led to trying to understand, are genetics influencing that transition from autoimmunity to joint disease, or do they influence the development of autoimmunity? And it's suggested that they may be more influential in that transition to joint disease. So we haven't seen associations with the shared epitope genetic risk allele in these studies and autoantibody locally. We've got some other individuals in our group who are looking at specific SNPs and whether or not they're associated with various antibodies, but so far we haven't seen anything in particular.